Thanks so much for joining us today, Dr. Wallach.
Great. Glad to be here.
I was just telling Dr. Wallach off mic or off camera that he was highly recommended by many of my friends when I went looking for a ketamine scientist. So this is very exciting. He's a ketamine scientist, but many other things have popped up in his research. But I'm very stoked that he's come on to explain to us a little bit how ketamine works in the body and what research has shown us so far. So if we could get started with a little bit about the biochemistry of ketamine and how it actually works in the body.
Sure. I think like any real understanding of a drug's action, we have to sort of generalize quite a bit. And in many cases, we don't really know. It's a lot more difficult, I think, than people realize to point to one effect of a drug and say that's definitely mediating this clinical effect. So with ketamine, there's still a lot of active debate about which of its various biochemical effects are involved in its therapeutic effects, its hallucinogenic effects, its dissociative effects. I would say the best sort of hypothesis is the fact that it blocks a specific type of glutamate receptor called the NMDA receptor. These are found throughout the body, typically on cell membranes. So, your cell is a little globule of fluid surrounded by fat. And in that membrane, you have all these receptors and other things that can communicate information from outside the cell to inside the cell. And so what ketamine does is it blocks that NMDA receptor. So it prevents that flux of information from outside the cell to inside the cell. So that's sort of the best, I guess, understanding of what it is doing. And other drugs that do that are like, for example, PCP, phencyclidine, angel dust. Another example is dextromethorphan or DXM. There's a drug, memantine, that's approved for use in Alzheimer's disease. That's also an NMDA receptor antagonist. So these drugs have a lot of different uses. And in addition, they all have sort of they cause these dissociative and hallucinogenic effects as well.
And what is it about blocking the NMDA receptor that leads to those effects?
Yeah, so that's not entirely known. Again, there's a lot of sort of research that's been done and hypotheses. The best sort of generalization, I guess, is those receptors are very important in signaling information throughout the brain. They're involved in connections between neurons, the synaptic connectivity. They're involved in learning, memory, sensory processing. So by disrupting those signals, you lead to this altered state in your brain that causes these effects. And to go a little bit deeper, it's, they've worked out some of the pathways quite a bit, at least as far as we know. One sort of complicated explanation is ketamine and these other compounds bind to NMDA receptors on inhibitory neurons called GABAergic interneurons. By inhibiting those, you disinhibit excitatory neurons, and then you actually increase the release of glutamate. And so you think ketamine's blocking glutamate because NMDA receptors are a glutamate receptor, but paradoxically, it actually increases glutamate in places like the frontal cortex. So you get this elevation in glutamate, and that is what's believed to mediate the dissociative effects, the hallucinogenic effects, and possibly a lot of the clinical effects, particularly with depression. But there are sort of debates about that.
Gotcha. And did I also hear, I believe I need to listen more closely, re-listen to some of my own episodes, but I believe we had Dr. Mandel talking about how it was increasing brain-derived neurotropic factor. Is that correct?
Yes. So that is one hypothesis of how the lingering or lasting antidepressant effects of ketamine work. So the idea there is, to back up, you have this elevation in glutamate. And what that does is it activates other glutamate receptors like AMPA, metabotropic glutamate receptors, and those activate processes in the cell that lead to the formation of BDNF, which strengthens synaptic connectivity between neurons. And so that's sort of the current hypothesis, but a caveat with that is many psychoactive drugs alter BDNF as well. And I'm not saying they do, they do it in slightly different ways, and so it's hard to generalize. But for example, cocaine, amphetamine, caffeine, a lot of drugs that we don't think of as antidepressants have similar effects in similar brain regions. And so it becomes a little bit less clear. It looks pretty in some of the animal models, but when we try to extrapolate it to humans, the evidence isn't as good. And as an example, there was a recent study done with a compound rapamycin that sort of, everyone in all these non-human animal models and this preclinical research showed that rapamycin prevented the antidepressant effects of ketamine in these models. When it was given to humans, it actually potentiated the antidepressant effects. And it's involved in this like BDNF pathway. So, we're learning a lot, and we really need to back everything up with human studies, because you can go on these wild goose chases with the preclinical animal work. It looks good, it looks exciting, but it's not really modeling what's happening in humans.
That makes sense. So speaking of, when did they begin to do trials on humans with ketamine as something other than an anesthetic for some of its other antidepressant type properties?
Yeah, so pretty early on, it was used, realized that it had analgesic effects or pain-killing effects. The depression wasn't till a bit later. If I'm not mistaken, I think it was early 2000s or maybe late 1990s. And a couple labs sort of noticed that, based on some various research, that it had this potential to have antidepressant effects, and they tested it and realized it was pretty unique, particularly with respect to like working in treatment-resistant patients and having a really rapid onset of action. Most existing antidepressants have, a delay in their onset. It takes several weeks before you see any antidepressant effects. Whereas with ketamine, they can be observed within 40 minutes and peak within a day or so.
And has that research that was the initial type research, has it been replicated several times?
Oh, countless. I mean, I would say that there's probably, there's a bit of a generalization, but I wouldn't be surprised at all if there's more evidence to support the efficacy of ketamine in depression than most other existing antidepressants. I mean, there are just countless well-controlled, double-blind, placebo-controlled trials that have been done with ketamine in various types of depression, and major depressive disorder, treatment-resistant depression, even bipolar, and a lot of different indications. But
so we'll stay on depression for a second. If you could give us a little bit of the efficacy details, how effective has it been shown, and generally for what period of time?
Yeah, so I do a lot of work with the pharmacology and the molecular stuff. I'm familiar with the clinical work, but I don't know that I can like rattle off every single trial.
Oh,
So
definitely not looking for it. Just just the trends.
I just want to make that
yes.
clear.
Appreciate
So
the caveat.
So sorry, the question again was
in the trends in the human research that's been done, how effective has ketamine been, and for generally what period of time does that effectiveness last, or how have they been able to maintain it?
Right. So they've done trials in just like major depressive disorder. A lot of the more recent work, particularly with S-ketamine, is done in treatment-resistant patients. So, it's a little bit, you have to be careful which group and cohort you're talking about. But, these are typically patients where they've tried an SSRI, an SNRI. The way it was defined in the FDA trials was at least 2 of these other trials that were fully attempted, and the patients failed to respond. And so in those patients, the response rates are very high. It can vary a little bit between the studies, but they're impressively high. Now, do they work for absolutely, everyone? No. There are certain people who don't seem to respond well. We don't know why that is. There could be genetic factors. They don't have, a lot of things have been speculated. Maybe they have metabolic enzymes. They break ketamine down too quickly. Some people have speculated there's different forms of BDNF, and certain ones might be better involved in the antidepressant response, but it's not really known. So the response is good, and it's very high. As far as like how long it lasts, that depends quite a bit, again, on the study and the patients. There's a lot of debate over even the best treatment paradigm. How do you give it? How frequently? What do you couple it with? So, it becomes difficult to generalize. There are certainly people who report very long-lasting effects. seems like in most cases you need maintenance doses, which can be from 1 to 2 weeks. Every 1 or 2 weeks, you would need a sort of booster of ketamine. But you'll talk to people, and everyone has sort of a different approach. And some people say you need that initially, but then you might need it once a month or even less frequent. So I think it depends. And the important thing to emphasize is, it's not like, I mean, it's close to a miracle drug, but not in the sense that like you can just give it and forget about it, right? You need to couple it with other treatments, diet, exercise, cognitive behavioral therapy, other approaches. So, that really needs to be emphasized. And in some trials, they haven't done that. In others, they have. So it becomes difficult.
Let's talk about, by the way, thank you. I'm writing all these notes down as you talk. Let's talk a little bit about how it has been found to be effective in PTSD.
Yeah, I know there's a lot of exciting work being done in there, in that indication. I'm not super brushed up on all of it. Again, I'm very fascinated by all the clinical work, but my focus tends to be more on the mechanism of action of these drugs and the chemistry. So, I've seen promising things in PTSD, but I don't know the nitty-gritty details and don't want to pretend to.
Fair enough. Can we talk a little bit about what has been found in relation to, or at least the areas that have been researched in regards to chronic pain?
Sure. Ketamine's been used off-label in pain in the United States and elsewhere for quite a while. It was realized early on that it has pretty potent analgesic effects. There are a number of different studies that have been done in both acute and chronic pain, and the consensus is that it does show efficacy in both various subtypes of acute and chronic pain. I would say the best research to date has been done in CRPS, chronic regional pain syndrome. This is a type of neuropathic pain that's very debilitating. These patients often don't have any other options, and so ketamine has shown great potential in that indication, both racemic and S-ketamine. Now, there's a lot of different dosing paradigms that have been done. In some cases, they're giving very high doses, actually essentially inducing a coma for several days in these patients. In other cases, they're giving smaller doses, so it just depends.
Interesting. You mentioned esketamine versus the racemic. Can you talk a little bit about that for people who might have seen in the news recently, FDA approves this other version of ketamine. Can you talk a little bit about what that was all about?
Yeah, sure. So certain molecules at the molecular level have a property called chirality. And sort of the everyday example of that's often given are your hands. So you have a right and left hand. And certain molecules have a right and left-handedness. And so, as you might imagine, the receptors in your brain also have this handedness. So certain molecules, that have this property, typically one of the forms, so in this case, esketamine, has the classic therapeutic effects. The other one, at least in humans, does not appear to. And I'm talking about the anesthetic effects, the analgesic effects. There's a lot of debate in the depression field, but in humans, only racemic ketamine and the S form, so the left-handed form of ketamine, have the antidepressant effects. People think R might, based on some animal research, but I would be very careful about extrapolating that. Those models don't have a very good track record of translating into humans. So I hope that makes sense. So it's just that certain molecules have this property, and then when you talk about ketamine, it's a mixture, 50% of the right-handed form, 50% of the left. What Spravato is, what esketamine is, just the left-handed form.
Okay.
They take it out and separate it. And so the reason they did that is they believed that this was the form that had the desired effects. The other one is just filler, essentially.
So what is the advantage of giving something that just has the effective form? Is it that side effects are more likely if you have both forms in there, or what's the advantage?
Yeah, there are a number of reasons it's done. If you ask a pharmaceutical company, they're definitely going to say that it's the better form, and you'll have less off-target effects, less undesirable effects. Often, and I'm not saying that's not true. It typically is to some extent, but it's often a way of patenting something in a new way, to be honest, which is fine. I mean, but that's typically, you'll see the racemic come out, and then once the patent goes up, then the isomer and enantiomer come out. This is just how business is done. But I think there is truth to that, why would you give a patient a bunch of a chemical that is not contributing to the therapeutic effect? Even if it doesn't have known toxicity and things, you don't know. Why even take the risk if you don't have to? So I think there is validity to that.
And so and this may be a question you don't know, but the average ketamine clinic, you said, is giving what you had termed racemic, which is the version of ketamine that has both of the right hand and the left hand version in it. Is that what most ketamine clinics are using, and who is using this new version?
Yes, so everyone who's doing ketamine infusions that I'm aware of, and unless they have some secret source or just started using something else, is racemic ketamine, so the 50-50 mixture. That's what's approved for as a general anesthetic, and so that's what's available to be used off-label for depression. It's not approved for use in depression or pain, only as a general anesthetic. Janssen and Johnson & Johnson recently developed Spravato, which is S-ketamine. That's just the left-handed form, and so that is only with the nasal spray Spravato at this point in time. Maybe there'll be other people developing various formulations, and then eventually, if it goes off patent, I'm sure there'll be generics and things.
Gotcha. Now, has most of the research that's been done so far been on IV only? Has there been any on nasally administered?
So with racemic ketamine, the majority has been done with IV infusion. But that said, there's plenty of evidence that it works through any of these other routes. I mean, pretty much anything, oral, intramuscular, intranasal, even less so. But there's probably, although I'm not 100% on the rectal in depression, but there's certainly evidence of rectal efficacy in a number of indications, and that wouldn't surprise me at all. So there's definitely more evidence for racemic. But again, Janssen did they did 4 very large, reasonably large, I'll say, phase 3 trials with esketamine. So there are large trials done with esketamine in depression, treatment-resistant depression, and other people have as well. They're not the only trials out there, but they're probably the largest that I'm aware of.
Gotcha. And that's the only indication that it was approved for at this point, treatment-resistant depression?
Yeah, in the United States, yes. In Europe, I believe esketamine is approved. Pfizer actually markets it. If I'm not mistaken, it says a general anesthetic, because that was the original work was done showing that esketamine was a better general anesthetic than R-ketamine and racemic for a number of reasons. But in the United States, yes, esketamine is only approved as an add-on therapy in treatment-resistant depression.
Gotcha. I just want to stop and say this is the most enjoyably nerdy conversation we've had on here. I have not talked about racemic anything since medical school, so this is bringing me back. I love it. This is great, and I hope the doctors listening are also getting a kick out of this. Let's talk a little bit. We went over a lot of things that I wanted to talk about, but I would like to get just a little bit into, because you do a lot with dissociatives and other drugs in that same category. Can you talk a little bit about the effects of ketamine that aren't necessarily okay, I'm tackling depression or I'm tackling chronic pain, more of how it works in the body that can provide more of a transformative experience?
Yeah, so I mean, a lot of people use dissociatives, I think, for this spiritual transformative experience, and it's pretty clear that they have that effect. So, I think, unfortunately, not a lot of research and controlled studies have been done on the impact of those experiences. But there's a lot of anecdotal evidence, and even, you talk to psychiatrists, and in some cases they're using it for depression and things, but there are people doing it out there for transformation and personal growth, and they report really excellent efficacy. Again, I think we really need to have it done under well-controlled trials, and I hope things are changing enough where something like that can happen. You see that with classical hallucinogens like psilocybin, where they have looked at those types of things in well-controlled studies, and you see pronounced effects. People who are drug naive saying that it's one of the top 5 most transforming experiences of their entire lives. So I would love to see more work done in that area, and not just for, of course, for spiritual growth, but I suspect that not for everyone, but for a subset of people with depression and maybe even PTSD, chronic pain, obsessive compulsive disorder, those experiences might have additional efficacy above and beyond what is occurring with, sort of the sub-hallucinogenic doses of ketamine that are currently being used. No one has really tried that. Again, we have anecdotal evidence that is the case for some patients, and it makes sense given all the work that's being done with the classical hallucinogens. So my suspicion is that is the case, and I would love to see it tested under rigorous scientific conditions.
Yeah. Do you know what research is coming down the pipeline?
In that regard?
Or just in ketamine in general? Like, are there new areas that they're looking to investigate? Not that I expect you to know all of ketamine research
Yeah.
worldwide, but
There's definitely some stuff in pain, and I should say, I consult in this space, so just to make it clear, in the pain space. So, just so your viewers know, and do some consulting with classical hallucinogen work. So, anyway, just as a full disclosure.
yes.
And so, yes, I think what's coming up next with ketamine, I believe, is going to be pain. But also all these other indications, psychiatric indications, particularly suicidality. There are countless excellent studies that have been done with ketamine for suicidality, and it shows just amazing efficacy, which is really exciting. And I suspect that is where some of the, if I was Jansen, that's definitely where I would be going next with this. So.
Gotcha. Well, I appreciate that. Is there anywhere that I should have asked you this before I started recording, but are there any trials that you are enrolling anybody into that we could advertise here? Because I know
No,
as a
I'm not.
scientist, there's not like, here's your website.
My expertise is preclinical, so my consulting is done more on the preclinical side. But just so.
Okay.
Eventually other people will do the clinical side of it all.
Well, I'm thoroughly glad that we found you to talk about the preclinical side, because we got way into the nitty gritty, but at a totally, I'm going to go ahead and just project here, but on a level that I think a lot of people who just kind of want a general understanding of how this thing works in the body. It's legal. It's now pretty widely available, but it's, some people may still have some reservations because it is a dissociative, and it is, has these other properties that people have heard of. So just to break it down and be like, this is basically what it's doing in the body, and these are the effects it's had, I think that will put a lot of people's minds at ease. So I really appreciate you coming on.
Yeah, sure, of course.
All right. Thanks so much. And everyone else out there, until next time.